Good afternoon, and welcome back from lunch. I am Regina Tan with the USDA's Food and Nutrition Service, and I'm here to open session number 3, where we begin to focus on changes in organ systems over the lifespan. We'll examine changes that occur as we age in cardiovascular, skeletal, and muscular systems, and highlight the role of nutrition on these systems as we age. Before we begin, I'm going to introduce our first speaker. You can find her full bio in the agenda at the workshop site. So first we have Dr. Tamara Harris with us to talk with us about the cardiovascular system. Dr. Harris is a senior investigator and chief of the Interdisciplinary Studies of Aging section in the Laboratory of Epidemiology and Population Sciences in the National Institute on Aging. Dr. Harris received her medical degree from Albert Einstein College of Medicine, New York in 1978. She trained in internal medicine at Montefiore Hospital, Bronx, New York, and in geriatric medicine at Harvard University, Division on Aging, where she was a Kaiser Fellow in geriatric medicine. From Harvard, she joined the Office of Analysis and Epidemiology at the National Center for Health Statistics. Dr. Harris moved to the National Institute on Aging in 1991. Dr. Harris?
Well, thank you very much for the opportunity to speak with you today. And unfortunately, I'm supposed to be somewhere else right now, so I'm going to have to leave a little bit early, and I apologize for that. The title I gave my talk is Selected Age-Associated Changes in the Cardiovascular System. And the three items that I would like you to take away today are that it's difficult to separate aging and disease in the cardiovascular system, that the changes in the vasculature are greater than the changes in the heart, and that the issues in the cardiovascular system are common, they're costly, and there are unsettled clinical issues involved in every one of the areas. So I'm going to give an overview. I'm going to talk about what I'm not going to talk about. I'm going to talk a little bit about atrial fibrillation and then about hypertension. Now, you might start off by asking whether cardiovascular disease is important in old age. And this is a figure that shows the age-adjusted death rates for the 10 leading causes of death in the United States. And you can see that heart disease, which is here, still leads cancer. And if you look down the other diseases that are on this list, you also see stroke and kidney disease, all of which are connected with the vasculature and aging. I'm not going to show morbidity, costs, and comorbidity, but those are also highly, diseases of the heart are very important. The beneficiaries, this is data from beneficiaries greater than 65 years of age from the Centers for Medicare and Medicaid. And you can see hypertension is at the top of the list, ischemic heart disease, hyperlipidemia, heart failure, and chronic kidney disease. So the importance of the vascular system with aging is high. Even if one avoids developing vascular disease until old age, this is from work from Dr. Ed Licata at the Baltimore Longitudinal Study on Aging. We have any coronary heart disease still is a high risk of developing this at age 70. This is women in the maroon and men in the beige. So any heart disease, coronary heart disease, coronary artery disease specifically, hypertension, you can see the just enormous incidence of heart disease in old age, hypertension in old age, heart failure, stroke, atrial fibrillation, and so on. Now, part of the reason it's so difficult to separate aging from changes in the cardiovascular system are shown here, where there are two different continuum. Here's one here, which is really based on atherosclerosis with the cardiovascular risk factors of dyslipidemia, diabetes, smoking, and obesity here. And here we have aging, where we have aging contributing to the fracture of the aortic to changes in the aorta, to aortic stiffening, and the sorting out to, leading to isolated systolic hypertension, circling around, and both of these processes eventually lead to end-stage heart disease and other diseases that are related to heart disease. So it's either through risk factors that are more lifestyle and environmental, or through aging that background changes in aging that you can reach the end-stage heart disease. Now, Dr. Jerome Flagg worked at the Baltimore Longitudinal Study on Aging for many years, and this is a quote that I took. He said, "The greatest difficulty in studying the effects of aging on cardiovascular structure and function lies in separating the effects of aging itself from disease processes and lifestyle changes." So these are changes that had to do with the heart that I culled from the literature. The modest left ventricular hypertrophy, about 30% change between 25 and 80. Systolic left ventricular function is unaffected by aging, and under normal function, and normal function is maintained without stressors. The left ventricular stiffening leads to slower filling and leaves the older person more reliant on atrial contraction for blood pressure filling, and the left atrium thickens and dilates, increasing the risk of atrial fibrillation. So here we have a diagram of the heart, the atria, the two atria and the ventricles, and these are some of the changes that happen with aging. There's dilation of the left atrium, calcification of the aortic valve, increased epicardial fat that's around the heart, and this has recently been shown to be a risk factor for coronary artery disease. The left ventricle might hypertrophy slightly, but there are changes related to fibrosis of the myocardium and to myocyte hypertrophy that lead the heart to be less responsive to stress. In addition, there's an age-related decline in maximal exercise heart rate and aerobic exercise capacity, which is total work or maximal oxygen consumption, declines with age. But physical activity actually can change this markedly and delay these effects. I'm not going to be discussing that today, but the role of physical activity is very important. And these are changes in cardiorespiratory reserve in healthy community-dwelling persons during peak cycle exercise between the ages of 20 and 80 years. And as you can see, basically peak oxygen consumption decreases, and cardiac index also decreases, as well as changes in the heart rate. Now lastly, there are age-related stiffening of the arterial tree, leading to increased systolic blood pressure and a greater load on the heart. And with age stiffening, thickening, and fibrosis and calcification of arteries, development of hypertension. These are mechanisms that contribute to cardiac aging. And if you think back to the presentations of the morning, that in fact they're quite similar in terms of the, some of the mechanisms that have been proposed. Mitochondrial reactive oxygen species and dysfunction, adverse extracellular matrix modeling, impaired calcium homeostasis. So all of these may have a role in the development of cardiac aging. And the idea behind this is that this is multifunctional. The consequences are that cardiac output falls with exercise as people age. There's an ability to increase heart rate in response to stress, decreased ability to increase heart rate in response to stress, an increase in aortic volume and systolic blood pressure, relatively no change in resting heart rate, but a decreased ability to increase the heart rate with stress, and orthostatic changes tend to increase. Now, this is really to remind myself. This morning, when Dr. Ferrucci was asked, what is the main biological functional sign of aging? And he responded, gait speed. Here we see data showing the association between gait speed and operative mortality for cardiac conditions. And this is to remind me that all of these changes related to cardiovascular aging are accumulating in the circumstance of other age-related problems, such as that might lead to decreased gait speed. So here what we see is that decreased gait speed is associated with increased risk of mortality, whereas higher gait speeds are associated with protective for risk of mortality. Okay, now there are things that I'm not going to talk about which are important to mention as changes with age. Pulse wave velocity increases with age. And what pulse wave velocity is transmission is hardening of the aorta in particular, so that there's a transmission of the pumping pressure, systolic pressure, to the end organs, such as the brain and the kidneys, secondary to aortic stiffening. So in other words, in younger people, the aorta dilates with systole. But in older people, because the aorta is stiff, there's no dilatation, so that the pressure from the pumping of blood from the heart is automatically ends in the organ system, such as the kidney, leading to damage over time. I'm also not going to talk about congestive heart failure with preserved ejection fraction, which is a very important disease of old age. Here we have some table that shows some characteristics. In middle-aged adults, the prevalence of congestive heart failure is less than 1%, whereas in older adults it's between 6 and 18%. It predominantly affects women, whereas in middle age predominantly affects men. The etiology is primarily hypertensive, and there's normal left ventricular systolic function, while the left ventricular diastolic function is impaired. And the subjects often have multiple comorbidities. I'm also not going to talk about kidney disease in relationship to vascular changes, but a very important area. The role of exercise and diet in ameliorating, if not reversing, some of these changes. And I hope that Dr. Chris Etherton will be discussing that. I'm not going to talk about atherosclerosis, and we've already had quite some discussion about inflammation, but I'm not really going to be discussing that any further. So what I'm going to talk about next is atrial fibrillation. Now, what is atrial fibrillation? It's an irregular heart rhythm caused by a disturbance in the electrical system of the heart so that the atria and ventricles no longer beat in a coordinated way. Most of the symptoms relate to how fast the heart is actually able to beat. However, increased risk of stroke is a complication. And this is a diagram showing the prevalence of atrial fibrillation and a related heart rhythm, atrial flutter, with age. And you can see that there's just a huge increase as people get older in the prevalence of these heart rhythms. If we look at the number of hospitalizations for atrial fibrillation, there's a rates per 100,000 person years by age group. We see that the rates of hospitalization go up markedly in old age. And if we look at risk factors for atrial fibrillation, the leading risk factor is actually increased age, which is thought to relate to fibrosis of the electrical conducting system in the heart. But you can see a number of other conditions here: hypertension, heart failure, valvular heart disease, and myocardial infarction, that all may be contributing factors. People with atrial fibrillation have multiple comorbidities as well. About 35% have none, and about a little less than 30% have only one. But you see the pattern that's quite common in old age of increased comorbidities. Now, the reason that I chose to talk about this is that there really are two issues having to do with atrial fibrillation in old age. And the first has to do with medication side effects and interactions and higher rates of hospitalization. But the second, which is really much more problematic, is that there is an increased risk of bleeding. So to protect people from risk of stroke, especially with chronic atrial fibrillation, it's recommended that people have anticoagulation. But for older people, especially people who may be at risk for falling or for falling or have some other risk factors for bleeding, the issue of whether or not to anticoagulate is a major clinical quandary that has not yet been solved. Okay, I'm now going to go on and talk a little bit about hypertension. So this is a picture of someone having their blood pressure being taken incorrectly. The picture shows someone with their sleeve rolled up, and technically you should not have anything constricting the arm above the blood pressure cuff, but we all know above the blood pressure cuff. If we look at the prevalence of hypertension, we know that the prevalence goes up markedly in old age, even higher than atrial fibrillation, and that somewhere around 76 to 79% of people aged 75 and older have hypertension, and in some studies that number is even much higher. What is hypertension? So these are young, healthy blood vessels. The opening is large and the wall is thin and responsive. Whereas in older individuals, the opening is restricted, and the wall has lots and lots of fibrotic changes and other changes relating to collagen. The endothelial, it's the inner lining of the blood vessel, may be dysfunctional. There may be vascular remodeling, increased stiffness, vascular inflammation, and calcification. And when people have looked at what's responsible for hypertension, again, it's a multidisciplinary focus, so that you might have aging here and you have pro-hypertensive factors that arise as a result of either just that arise as a result of people, of lifestyle factors, or can result as a result of conditions that might increase blood pressure. So okay. And if we look at the differences between midlife and systolic hypertension, midlife blood pressure tends to involve both diastolic blood pressure and systolic blood pressure. Blood pressure control is relatively easy. The prevalence is 30 to 35% of people who are in their less than 55. There's atherosclerosis is involved, whereas in older age, it's primarily the systolic blood pressure that's elevated, and the diastolic blood pressure is normal or low, which tends to make control of blood pressure sometimes difficult because the diastolic blood pressure drops as well as the systolic blood pressure. That there's increased aortic stiffness, and we saw how the prevalence increased with age. Now, it's important to recognize that hypertension also causes changes in other organ systems. And although I didn't talk about the kidneys, I'm just going to mention briefly the issue of cognitive change. So this is one of a number of studies that have looked at the relationship between hypertension and cognitive change, and found that this is over looking at a 20-year change in the scores on these tests. These are people who had pre-hypertension, these are people who had hypertension, and these are a variety of types of cognitive testing. And you can see that those people who had hypertension actually had much greater changes on their testing 20 years later. In addition, these are data looking at physical disability risk, and you can see that this is looking at normotensive individuals, people who have controlled hypertension and uncontrolled hypertension. And the uncontrolled hypertension have incidence of change in the physical functioning that's much higher. Now, this is back in 1979, and I know that nobody in the room is old enough to remember 1979, but I think it's important to think back to where we were for the treatment of hypertension in older patients. So this is the treatment of hypertension in patients under the age of 65 is well established. The case for treating essential hypertension in patients aged 65 and older is less firmly based. Not only is the evidence conflicting and insufficient, but there are doubts about the case for treatment a priori. So this is the prescribing of potent antihypertensive drugs to every elderly person with high blood pressure will benefit a few, will harm many, and will be wholly irrelevant to the medical needs of most, especially of those in whom high blood pressure is an incidental finding and not the cause of the symptoms for which the patient has sought medical care. We do not know in which patients hypertension is a disease and in which it is, like old age itself, an achievement. So doctors are advised to curtail antihypertensive therapy in the elderly until much more is known about its effects. And there was actually some very strong support for this statement back before the major clinical trials. And it related to the fact that the people who survived to old age actually had high blood pressure. So it was thought that somehow it was linked to survivorship, that the brain needed high blood pressure in order to function properly, and that autoregulation of blood pressure would be disrupted by treating blood pressure to a lower level. However, there were many major trials for the treatment of hypertension, and I've noted here the ones that have to do with primarily elderly individuals or that had a strata of elderly individuals. So where we are currently is that recommendations are to treat older people to a systolic blood pressure of about 150 millimeters of mercury and no lower than that, as opposed to earlier recommendations which had suggested that 140 was a better level. So, however, since that recommendation came out, the SPRINT trial was published, and I'm just going to show you a little bit of data. This trial, I think, is very important because they recruited sufficient number of older people, these are people over the age of 75, that they could actually create a strata. And furthermore, they looked at gait speed, and they looked at frailty status, so that not only did you have the level of blood pressure, so these were people whose systolic blood pressure on average was about 141. Their diastolic was about 70. And the idea was to continue to treat them down so that they could see whether there was a continuous relationship between blood pressure and outcomes. And in fact, the trial was stopped early because it was so successful. And this is looking at the cardiovascular disease primary outcome. You can see that there were 102 events among 1,300 people who were in the treatment group and 148. And you don't have to really do many statistics to know that that's going to be a significantly different p-value. Okay. And I just wanted to show this last graph, which is the level of fitness. So this is the people who are the most fit, and you can see that standard treatment, this is, so it's cumulative hazard of outcome. So the standard treatment is here, and the intensive treatment is here, but even for the groups that were next most fit and the group that was least fit, who accumulated more events. But even there, the standard treatment was less effective than the intensive treatment, suggesting that, in fact, older individuals who, at all levels of fitness and frailty, would benefit from blood pressure lowering. This is a meta-analysis that came out in Lancet just recently, and blood pressure lowering, I'm almost done. Blood pressure lowering below current recommended levels decreased risk of heart disease. There was no threshold below which lowering blood pressure did not decrease risk. There was consistency between the studies in the effective treatment, and drugs specific to the outcomes worked. So even within the general guidelines for treatment of blood pressure, there was ability to tailor the treatments. However, as you can see from this article that appeared in the New England Journal in May of 2008, we've passed this way before and had other trials which have focused on treatment of blood pressure in older individuals that were successful. So it's not clear exactly what the future will hold in terms of recommendations for older people. So what I'd like you to take away is that it's difficult to separate aging and disease, that changes in the vasculature are greater than changes in the heart, and that diseases of cardiovascular tree are common, costly, and unsettled clinical issues. So with that, I'm going to end. Thank you very much.